Hi there, folks. I'm sorry, you probably had a couple seconds of quiet there as I have no way of seeing how many minutes have passed or seconds or whatever. Any rate, this is the recording of the cesarean delivery that I'm going to be going by, and I think that you're seeing now indications as opposed to the main screen with all the side screens. So I'm just going to go off of that. You know my technical skills here in recording. So let me go back to the first screen because there's a lot of information that's really important. So cesarean delivery, the definition is the birth through abdominal and uterine incision. Was Caesar the first person? Who knows? It's a good story. But it's amazing when you think of how many babies would not be alive and how many moms wouldn't be alive without this alternate way of delivery. So in the United States, like this says, cesarean deliveries were not that common. So we have gotten much better at them. We've also decided when we need to deliver by cesarean a lot quicker than we used to. So the 5% and 65 doesn't mean that we've gotten worse at delivering vaginally. It's just that we are starting now to deliver not starting now, but we have gotten to deliver more. This 32.7% is really kind of outrageous. That shouldn't be quite this high. And as that pendulum swings to, ooh, we have one bad decel, let's deliver by cesarean, that we will be bringing it a little bit less. Our aim is to bring it down below 30%. 25 would probably be good. So we have a ways to go. This figure is from 13, although this is 2018. It takes a while to get really good figures. This cdc.gov site is a really good source for all kinds of statistics. So you could look at that if you're interested ever in your life of knowing more statistics than what we give you. So our indications are many. Look at this. There's reasons that the mom is not doing well, and there's reasons that the baby isn't doing well. The first one here is a repeat cesarean delivery, and yet we have a VBAC, vaginal birth after cesarean, that can happen, that we don't have to have once a cesarean, always a cesarean. And a lot of this is the comfort that doctors are getting to deliver, to allow a mom to deliver by vaginal route who was once a cesarean mom, because we know more about it. There's more comfort level. Where we put that incision has a big thing to do with it, and we'll talk about that later. Another reason for the mom to have a cesarean is an obstruction. We can't get past certain things. The baby just isn't going to move past maybe a large malignant fibroma of some sort. Condyloma is that active herpes. Actually, condyloma and herpes are different. Condylomas are HPV, and there's a lot of grape-like swelling that we just don't want to bring a baby delivered through. And the same with active vaginal herpes. Active oral nasal herpes is no reason to not deliver by the vaginal route. A vaginal septum isn't all that common, but it would be an obstruction. And other tumors, a pelvic abnormality that would prevent that head from engaging. So the mom's pelvis is not of the optimal type to deliver a baby through, or the mom had pelvic surgery, or the mom had broken the coccyx a number of times and it is no longer flexible. Lots of reasons. So these are not all common, but they're reasons that perhaps would make a doctor and a mom say, let's just deliver by cesarean. Dystocia, difficult, painful labor with complications of the powers where the uterus is not contracting anymore to push the baby out. The passenger is too big, is not faring well, or the passageway, again, there's a blockage. Cervix isn't opening, that's part of the passageway. HIV counts above 1,000 and treated with antiretroviral therapy, but that may also be a reason to just deliver by cesarean to actually avoid a lot of the contact with blood. But you think, wow, cesareans are really bloody too, but we could maybe control that better with the baby. Severe mental illness. Now this is an interesting one, because if a mom truly a woman has no idea what labor is going to entail, they weren't really quite sure how they got pregnant, taken advantage of, things of this sort, a rape, Are they going to understand the intensity of a labor? So perhaps it is more humane to have that baby delivered by cesarean than to have her go through labor. It's a valid reason. And to reason at the final one that a mom or a baby would be compromised. We're never going to just see what happens if we can anticipate. If our past has told us that a baby may not do well or a mom may not do well, we're not going to jeopardize either of them in this situation. So then the reason that the reason that a baby would be presenting to have a cesarean would be prevention of death or injury. Always a good reason to go ahead and deliver. And a prolapsed cord very frequently cannot be pushed back beyond the head. Things of this sort, we can relieve the pressure from the cord until that baby is delivered by cesarean. But compressed cord is not a good thing to happen because babies need that blood flow. Malpresentations like a breech or a transverse lie. Transverse lie is really not going to be corrected. Depending, of course, everything's depending. But if that baby has been transverse for a very long time, a number of weeks, to think that that baby is going to rotate and be vertex is not likely. A breech baby could be turned into a vertex. Sometimes they stay, sometimes they don't. That's called version, external version, and we'll talk more about that. Certain malformations and skeletal disorders, like a neural tube defect, would not fare well with a vaginal delivery. There's a pouch over nerves that are exposed, that are not hidden under muscles, and to deliver by cesarean would not risk the rupture of that sac, and therefore the exposure of those delicate nerves to the very, very alkaline and caustic amniotic fluid, and then all the pressures that would go on with a vaginal delivery. The baby's head is large, hydrocephalus. Often also happens with a spinal cord deformity that the fluid from the ventricles does not drain well, and therefore the head becomes large, and that's a birth injury waiting to happen. And moms have difficulty delivering a head that is larger than it would normally be. A multi-fetal gestation, where the first baby, the first twin or the first triplet, the first baby, is non-cephalic. So again, that breech, it's hard enough to turn a breech baby to vertex, much less with another baby or two in the uterus. So although if the first one is cephalic, we can deliver by vaginal and often reach up and turn the second baby to be cephalic. So lots of decisions that are made just in those last kind of 10 minutes of birth. Taking a sip of coffee, thank you. Infection. Again, we don't want to bring a baby over an infected area, and maybe that baby isn't doing well if the mom is infected, if the baby has an infection. So we always have to be on the lookout for symptoms of infection like increased heart rate. Prolonged acidemia. This is where the baby's not perfusing well. Baby's getting blood value is getting acidic, and they're just not going to survive. So we're going to deliver that baby as soon as possible. We used to do scalp samples to see how acidotic the baby is becoming. We just deliver the baby now because by the time we would get the results back, we would have the delivery over. A placenta previa, that placenta is down low over the cervix or just even low to the cervix. Baby's not going to get through it. And an abruption where that placenta comes off of the wall, not even 100%, just enough that the baby's not going to perfuse. So we need to get that baby out of there. And then that cephalopelvic disproportion with those initials of CPD. The baby's too big for the mom's pelvis. It may be a 5-pound baby, but the way that baby is presenting could be that that baby is just too big for the pelvis. And potential birth injuries is that very valid reason for a cesarean. So we're not going to risk anything. Okay, let's get the second slide down here. So a prevention of cesarean delivery. It'd be nice to think that we could prevent it. If that baby is breech or transverse, this external version can be done. And it's like this says, about 60% successful. If this is the one that we're looking at, let me move this one down. Manipulation of the fetus to a cephalic presentation. It's guided with ultrasound, so we know where the cord is. We know where the baby is within this pelvis. We're going to make that uterus very relaxed. So we're going to give a tocolytic to get that uterus not at all tense and tight and hopefully not contracting. We would not do this if a mom was in labor. So it's getting this head to move down and turning the body. I'm kind of demonstrating this that you can't see. And very gently but firmly teasing this baby's head down into the cephalic position, and then holding that head there for maybe 5 or 10 minutes. Doctors do this, nurses do not do this. So the baby can kind of situate the head, get the body back in a comfortable position for the baby. Very often, 40%, they're going to turn back again. Excuse me, so that it is better than 50%. Maybe it's a reason to go ahead and try this, but they do flip. There's also a reason for not doing this is placental bleeding. Maybe separating that placenta from the uterus, never a good idea. Cord entanglement. We may start labor just because we have so much manipulation. Rupture of membranes, ROM, and injuring the fetus. So this is not done again at 39 weeks. This would be done more 36, 37. If the doctor's thinking this baby's not going to turn on his or her own, and the mom does not want perhaps a repeat delivery, cesarean for a breech baby. So lots of reasons why we could do this. Again, we're going to relax this uterus with terbutaline. But done sooner than 36, that baby may kind of go back to being breech. So it really is a delicate, when do we do it, when do we do it, when do we do it? Okay, now's a good time, and then just see what happens. So some reasons to do this would be this rise in cesarean rate, increased use of epidurals. That could be the reason for cesareans. Maternal age over 35. We don't have a whole lot, but that number is increasing as women are having second and third and fifth babies when they're over 35 years of age. Maybe they didn't start to have babies until their 30s. A failed induction might be another reason to start the cesarean. If we induce and then it doesn't work, then we have to have an induction. Reduced VBAC deliveries because moms are not confident that they can have a vaginal birth after a cesarean. And then a lot of doctors just will do a cesarean. In a sense, they're easier than a loss. And so if there's any doubt at all that this baby or this mom may not survive, we're going to do a cesarean. So prevent it as we may, sometimes it's just what we need to do. And let's move this one down. Come on, where's my cursor? There it is. Okay, so controversial indications. A mother's request of cesarean on demand. So the ACOG, American College of Obstetricians and Gynecologists, we used to have an organization called NACOG, the Nursing American, but now that's changed to A1. So a little bit of trivia thrown in there. We do not support the physicians or the nurses that a mom's request to do a cesarean. So it used to be, you know, I'm tired of being pregnant. I'm 38 weeks already. Let's get this done. I start a new job in 42 weeks. You know, when I would be 42 weeks, I want to deliver this baby before I go back to work. All these different reasons. So just because the mom wants a cesarean is not a valid reason. There has to be a medical reason for a mom to have a cesarean delivery. Doctor's convenience was never really a valid reason. No, it's not because their golf game started in a couple hours that they would go ahead and do a cesarean. Cesareans should be a defensive action warranted by events in labor. Rates of cerebral palsy or neonatal surgeries, neonatal seizures are not impacted with a rising number of cesarean deliveries. So it's not that there is harm of the baby because we have done a cesarean. It's never a reason to do a cesarean. So again, this maternal cesarean delivery on maternal request, never a good idea. We're actually not doing cesareans until 39 weeks. Oh, maybe 10, 15 years ago, we would do a cesarean when the mom reached 38. But are we really sure that baby's 38 weeks? And one of the worst things that could happen is delivering a baby too early. We think that baby's 38 weeks, let's say. Baby turns out to be 36 weeks, which is really a late preterm birth. And unless we're checking dates very, very early with an ultrasound around 6 to 8 weeks, like we talked about in antepartum, we really can't tell how mature this baby is at 36 weeks, 37 weeks. So we're just not doing anything until that mom has, on those wheels, wheeled out to be a 39-week. And then there's probably a good chance that those lungs are mature. It's also not recommended for women who want more children because there is this known risk of a placenta previa with a mom who has had multiple repeated cesareans. The accreta, where that placenta embeds itself actually into the uterus with different degrees of surface into the uterus or through the uterus. A gravid hysterectomy is a hysterectomy right at childbirth could be increased with each cesarean delivery. So that's a reason to not have one just because a mom wants one. It has to be a medical reason because there could be more complications whenever she has a future child after that. So there is this potential risk of hemorrhage for that mom and decreased. So let me read this better. It will, however, kind of concede that there is a potential risk of decreased risk of hemorrhage for the mom by doing a cesarean. That's a statistical number. Sometimes moms can hemorrhage after a cesarean if all those tissues aren't closed up well. So it really requires counseling for those potential risks. And here is this eMedicine website for finding out more information on it. So bottom line is that cesareans are not done just at the request of the mom. There has to be a medical reason for that. So all of our patient teaching that goes in, if we're anticipating a cesarean delivery, then it really is part of the physician's, obstetrician's role to do patient teaching. If a mom has come into the hospital and requires a cesarean, then we have to hurry up and do some of this teaching. There are as many as emergency cesareans. We kind of know that a cesarean is going to be necessary because of where the placenta is sitting, because of her slowness of going into labor, and we're thinking there might be a cesarean. But if we know that a mom is going to have a cesarean, that it really is important to teach her all along. There are cesarean delivery classes, just like there are delivery classes for vaginal deliveries. So all procedures in a hospital require patient teaching. We just don't do anything without the mom knowing. That is one of those lawsuits waiting to happen. There are, I will repeat, and we're going to talk about this in the legal part, 50% of all lawsuits involve a maternal incident, an obstetric incident, something that should be normal. So we have to be really careful and be very judicious and proactive. So everything that we do to a patient, we tell the patient about. We make sure that they understand what's happening. And again, cesarean classes for childbirth. Anesthesia choice, it should be an epidural or a spinal. It's the only way we can deliver these babies. There's no other way. We're going to talk to her about what she's going to be feeling. She's going to feel some pressure as we're pushing this baby out, fundal pressure. She's going to be hearing a lot of clanging of instruments. The obstetricians are very careful to control their conversation during a delivery, especially if the mom is not going to be sedated. There's a lot of back and forth talk between the nurses, between the circulating nurse, between the nurse that's waiting for the baby at the warmer. All of this really good stuff is going to be explained to the mom so that she can anticipate and understand. The person who's going to be sitting with her, it could be husband, it could be FOB. Sometimes FOB wants no part of the delivery room, and her mom, her sister, her cousin, a friend, somebody. It's nice to have somebody there for her who's sitting on a stool at her head so that they're also included in all of this teaching. Holding and breastfeeding of the baby in recovery room, but also holding this baby right after delivery. it's much more inclusive and much more, we're trying to reduce those barriers of well, you had a cesarean, so you couldn't hold your baby right after delivery. But that's not true anymore. Baby is delivered, baby is shown to mom. There's a screen that's going to be in front of the mom so she can't see what's happening. But baby will be held up over the screen, beside the screen, taken to the warmer bed because that baby didn't have that vaginal squeeze. The baby doesn't have the clearing of the airway like they would had they been delivered vaginally. So we'll put the baby in the baby warmer, dry the baby off, suction if necessary, get that baby crying and pinked up, and then dressing and putting blankets on the baby so that the baby can be held by mom, and even breastfed, taking down the mom's gown and realizing there's not a whole lot of space between that screen, but we can establish breastfeeding, we can establish skin to skin. It's really how much we want to do and how willing we are to be very creative, and how much the mom wants of this experience. So it's really important that we're asking the mom and the dad what they had always anticipated of their birth experience being. Taking pictures and videos, we don't encourage pictures of the open abdomen. Some dads will stand up and take pictures beyond the screen until they're told not to, kind of a deal. But would they really want to see the inner workings of the baby's mom? So it's almost like, okay, but let's explain to you what you're seeing here in these pictures. And then talking to them again about the immediate recovery and the postpartum, probably going to be a day longer, as you've probably found out by now, by caring for moms who have had cesareans. So preparation of mom and family goes along with this. Is a consent really has to be signed ASAP. We can do nothing without that mom's consent. So very often, truly, it's as they're being wheeled back to the delivery room, they're signing their consent on the clipboard and we're talking to them. If this is an emergency, abruption, cord prolapse, this kind of a thing. We also want to help that mom maintain control. So we are commonly saying here, sign these consent forms, but we don't want this mom to be really excited. So there are people coming up into the floor here. I'm going to pause this and close my office door for 2 seconds. Okay there, Dr. Schwartz is now in the house. So yes, help them remain calm. And for them, it's the birth of the baby. It's not the surgery that she's going to have. Although she's concerned about what's going to happen. If you've established trust with this mom, she's going to trust you. She's going to trust the doctor. We need to tell her everything that's going on. But she's going to trust us. So no fluids for 2 hours beforehand. Obviously, in emergency, we can't control that. But if a mom is coming in for an elective cesarean, we don't really want to give her 2 hours or fluid for 2 hours before. If we're thinking she might have a cesarean, we're going to back her off of those. 6 hours after a light meal. Again, we don't want her eating before this elective one. And 8 hours after a regular meal. So moms are coming in for a cesarean, they shouldn't be eating. We used to keep moms in overnight the day before, but not too expensive. So we just asked them not to eat breakfast, and they'll have their cesarean almost first thing in the morning. So these antacids, Bicitra, it was given to neutralize the stomach contents, just in case they would aspirate, because we couldn't withhold food and drink. So talking to nurses now, they say that's not really given. It's more of a decision. Well, they just were drinking a lot that's given by Citra, or they haven't had anything by mouth. So in your book, however, it does talk about antacids. A lot of other printed documents will talk about Bicitra. It's an antacid. It is the most horrible, awful tasting stuff. So you give it to them in these little ounce cups, and you tell them not to lick their lips, just tug it down, just kind of throw it down. If they were taking shots, just throw it down. Don't lick their lips, and we cannot give them fluid afterwards, so just don't taste it. It's really awful. An IV, yes, we're going to start an IV of lactated ringers or saline with some energy source, 5% of dextrose. If it's not already started, we're going to start that. A Foley catheter is going to be inserted, and that's usually after anesthesia, so that they don't feel the catheter going in. We try to, again, make this as pleasant a situation as possible. Some places, though, will put the catheter in the hospital room, and the mom will walk into the delivery room holding her urinary collecting device. Or they'll walk into the delivery room and get on the table themselves rather than being wheeled in and having to be transferred over. Again, as much normalcy as we can make this delivery the best it's going to be. We're going to have EFM, electronic fetal monitoring, and if it's external, we're still going to continue with the external. If it is an internal, we're going to remove that spiral and continue recording externally until the abdomen is scrubbed. But we don't want the baby to be born with that spiral electrode still in the scalp. We're going to be taking the blood pressure of the mom. We're going to have a pulse ox of that mom. So as much as we can, we're going to monitor mom and baby. And until we scrub that abdomen, we're going to be listening to baby. We're going to be giving her antibiotic prophylaxis. It's given by anesthesia. Very often this is given once that cord is clamped of the baby. If we're thinking baby like needed penicillin, some other antibiotic because of group B strep, then anesthesia is going to be giving that. It's no longer a nursing responsibility. They're going to be evaluated by the surgeon. They're often evaluated by the house physician, and they're evaluated by anesthesia before they have any kind of moving into the delivery room to see what sort of anesthesia they need. If they've already had an epidural, their levels will be tested to see if it's high enough. The surgeon, the obstetrician will be making the incision very low, like into the pubic hair sometimes, to avoid an area that is not anesthetized. And a woman with an epidural doesn't have to have a higher level. Anti-embolic hose, those alternating compression boots, or the alternating compression boots are really the best thing to put on. If not, we're putting on those TED hose. Women have died because of clotting being on the table for so long. So a lot of the things that we're doing now is to prevent things that have happened in the past, quite frankly. So we're going to have her on her back. Obviously, she can't be prone, but we are going to tilt her to the left. All of our newer delivery tables, we can crank to tilt that mom to the left. She's going to feel like she's going to fall off the table. We're not going to let her fall off the table. We're actually strapping legs down and maybe a strap higher, kind of all depends, a strap across the thighs so that she doesn't fall. If we don't have time to do that for whatever reason, or it's an ancient table, we're just going to hold her over and throw some IV bags over under her to tilt her off to the left. That was done a long time ago. Kind of another trivia point. The abdominal scrub. We're going to start at that incision line, which again is, we're going to talk about that later, but it's usually around the suprapubic line, and we're going to scrub from there. We're going to scrub up very often to xiphoid, and we're going to scrub down to the middle of her thighs. We're going to scrub 3 times with sterile swabs, cleaning mons, thighs, groin last. Then we're going to paint with an antiseptic. What is used, whether it's a betadine or chlorhexidine, is really whatever's done at that hospital. And then we're painting with this antiseptic and allowing it to dry, mopping off a lot of it, but allowing it to dry, because when it's dry is when it's most effective. So then we're putting drapes on, we're covering up her face so that she can no longer see anything and letting her know. Actually, one of the really nice things is that drape in front of her face, a lot of places are using a clear plastic so she can actually see this baby. She's not seeing the incision, but she's seeing the baby being brought out, kind of similar to seeing the baby being delivered vaginally. Baby's being brought out and held and shown through this plastic so that everything is still sterile on the operative side, but mom can see. And then they're going to raise this occlusive drape again so she doesn't see the repair. What happens after the baby's out is that uterus is actually brought out and on top of the drapes on top of the abdomen so that they can take a look at the incision, close it better, make sure that placenta is out, look at the back of the uterus to make sure there aren't any tears. and it's a good way to heal. Sometimes moms have more gas, but we can take care of that. So we don't want that mom seeing that her uterus is out on top of the and out of the abdomen, on top of her abdomen and out of the abdominal um, space. So prep before delivery, document fetal age. Oh my goodness, is so important. And fetal lung maturity. Unless it's an emergency, cesarean is not done before 39th week. Again, one of the worst things would be delivering a baby too soon when we could have waited. We're going to do that complete blood count. We're going to see what her H&H is. If she was a little on the anemic side, we're going to perhaps give blood afterwards, maybe give blood during. We want to see absolutely her type and cross. And whenever we find out the baby's type through cord blood, see if she's going to need ROGAM or not. We don't know up to this point. We're going to cross match her. Every place should cross match, at least have something waiting for her, because we never know what's going to happen. As efficient as we are with cesareans, things can happen. We're going to screen her for HIV, hepatitis B, syphilis, new or existing results. Sometimes this has never been done, especially mom. The worst case scenario is mom comes in, says she had a cesarean before. We can see some kind of a scar, and she's in labor, so we need to deliver her. We're going to get blood tests done because we don't know her. We're going to do coagulation studies, prothrombin activated, a PTT, and fibrinogen levels, just to see what we're working with, if she's going to clot or not, or perhaps, we talked very little bit about this, but disseminated intravascular coagulation, DIC. We're going to document that fetal position, that it was vertex, it was breech, it was whatever, and give this estimated fetal weight by ultrasound, whatever last ultrasound she had. And the nursery nurse is present to give care to the newborn. It is not expected that the circulating nurse, who's circulating, giving more supplies for the delivery, is then also going to take care of the baby. We've learned to have more people in the delivery room than we ever thought would be necessary. So, nurse's responsibility during a cesarean delivery. We're going to have at least 3 nurses, a circulating nurse, the scrub nurse, and the nurse for the baby. Cesareans are expensive. They have OR time, they have doctor's time, and all of these people taking care of them. So the circulating nurse, she's the one that's moving around like crazy, counting out things and getting things. She's going to put on the records the start time, the time out. We're checking mom's ID bracelet. We're saying that she's here for a cesarean, for the reason for the cesarean. All hands are off the mom, nothing is done, and this is before the incision. Timeout should also be being done before circumcisions. So they are noting what skin incision is done. Again, we're going to talk about the different kinds. Any tissues removed, baby delivered, placenta delivered. If mom's having a tubal delivered. On a repeat cesarean, the old scar is going to be actually cut out, and new skin is going to be anastomosed together, so that she has a really good healing of her incision. If any other kind of tissues are taken out, that circulating nurse is going to identify them and then take them down to pathology or send them down. She's going to add instruments to the table as requested. Lap pads are often, more of them are put on the table because they need to soak up more of the fluid and the blood that comes out. Receiving specimens, helping getting patient on and off the table, determines correct instrument count. Absolutely, that mom is not closed. Her peritoneal layer is not closed, her fascia is not closed, her skin is not closed, without making sure that all these counts are accurate. The really cute commercial, maybe you've seen it, of the phone that has fallen into the incision, and Siri is responding to it. Of course, that's not going to happen, but it's just this kind of cute thing. At any rate, as the lap pads are used and absorbed, they're just kind of tossed off to the side. There's a bucket often that's down on the floor, and she's going to take, he or she, scrub circulating nurse is going to take those lap pads and organize them so we can count them. There's kind of like a shoe holder thing that's on an IV pole now that has arranged these lap pads in numbers that we can count very quickly. The scrub nurse is going to set up the table. She's going to be sterile. She's going to go in. She's opening the tables. She's going to have scrubs. She's going to put gown and mask, head covers, shoe covers, gloves on, and she is doing all of this in a sterile manner. Helps with the sterile gowning because she is now sterile, hands instruments to doctors, clears the field of unwanted items like instrument lap pads, suture materials, skin taken off, placentas, all this kind of stuff. And she and the nurse and the doctor are going to be counting to make sure that we have left nothing in the body. So let's go down to this one. So different kind of skin incisions that I have alluded to before. The fan and steel is a skin incision. Fan and steel is not what's in the uterus, but it's when you look at the skin, it's this sideways transverse, very much around pubic hair start or into the pubic hair. However, we cannot tell how the uterus is incised. We can just see this. It is less painful for the mom to recover. It's less prone to herniation. And again, cosmetically preferred. If they're done well, then after a year, the mom isn't even going to be able to see that scar, and she can wear her bikini. It often was called the bikini cut. The infraumbilical skin incision is vertical on the skin and used if incisions are expected. And this skin incision is this infraumbilical. What we're looking at here in this picture where I'm moving the cursor is really the incision into the uterus, but we can have a skin incision that is below the umbilicus down to the symphysis pubis. If this mom, it's like her second, third, fourth, 10th, 8th cesarean, she's going to have adhesions, and these are extra thick scar tissue that's kind of holding the bladder and the lower segment of the uterus, and it can take 20 minutes to cut through that. If we don't have 20 minutes, then we're going to go up higher with the skin incision so that all of that is avoided. We could still put the uterine incision as this low transverse, and if you've gotten a report from a cesarean delivery and we say a low transverse incision, that's the uterine incision. She's going to have probably a fan and steel skin incision, but the low transverse is that incision on the uterus where it is low. Again, it's less blood, it's less active. The mom can have a VBAC with this kind of an incision. And actually, this is what a lot of the times, even within emergencies, cesarean is going to be done. It could be extended up to a vertical, so it's either an extension of a low transverse or it starts just out with a low vertical incision, but still not going into the contractile part of the uterus. Decisions have to be made if the mom's going to have a VBAC after this. This classic incision is where an incision is made through the contractile part of the uterus. Moms cannot have a VBAC after this, but sometimes there's a placenta that's blocking the way, or we have to get down to that baby in 2 minutes, like this says. We can get down to that baby in 2 minutes after it's called. That's quick. We're not concerned with cosmetics or adhesions after this time. We're just going to do an infraumbilical skin incision. We're doing the classical cesarean incision. We're getting that baby up and out and hopefully still alive, quite frankly. Delivery of the baby's head is the most important to facilitate. We can anesthetize even before that, not anesthetize. We can help that baby breathe. My goodness, I'm blanking on that word. To even with just that head out. So baby's delivered, mom is sutured up, all the skin is repaired, uterus is repaired, uterus is put back into the abdomen. We get mom off the table, we clean mom up, we put pads in place, and she is in recovery room. Do you see here how I have a lot of asterisks STRI, put between vitals, pulse ox, her urinary output, as well as her bleeding output. Vaginal bleeding, bleeding from the incision perhaps, are so incredibly important in recovery room. She may still have cardiac monitoring in place that the anesthesiologist put in, because that was done during delivery, and maybe something was seen that the mom still needs to be monitored. We are checking this fundus to make sure it's firm, but we are gentle once her sensation is returning again. We're actually going to be expressing any blood just like we would after a vaginal delivery, and it's painful, but we have to make sure that she is firm and that we are not having any retained blood in there. We have to really push on that uterus. It's going to hold. All those stitches are going to be good. We're not going to rupture anything, but we have to get that bleeding out, because if it stays in the uterus, it's not going to allow for that uterus to contract and involute. She is going to have return of sensation, hopefully, at some point in time, and her level of consciousness is going to rise again. Very often, a mom's going to be given Versed or something to kind of put her under a little bit after that baby is delivered. It just helps her relax. This again is something that's going to be agreed upon. Does she want to see this baby as long as that baby is in the delivery room? So a lot of times mom and baby are brought to recovery room and bonding continues there. So we're not necessarily going to give her anything that's going to relax her. And again, it's the anesthesiologist that's going to give her that. IV fluids and diet are advanced as tolerated. Again, depending on bowel sounds, we don't feed them back in the recovery room, but we are going to feed them once they get back to postpartum. It used to be the way to do it was to start with fluids and clear liquids, and then fluids, and then a soft diet, and then food. But we are finding that the sooner we advance them to solid food, the better their bowel sounds return, and they have less gas that just sits in their abdomen. They're able to pass gas better. So as much as we say, no, we've got to give her fluids first before we give solid food, we're finding that solid food isn't so bad. We're also finding that letting her chew gum and stimulate these gastric juices is going to help establish bowel sounds faster, and she doesn't get this gas distension that is so common after a cesarean. So long-acting analgesias are going to be given in the OR. They're usually IM or IV. It's Duramorph that we're going to be giving. We could give a PCA of some kind of medication that she has, and that she controls the amount delivered to keep her pain at a tolerable level. We're going to give her oral analgesia. Very often it's a narcotic along with a Motrin, and that's a nice combination. If we're giving Duramorph or giving any kind of a opioid, we have to assess her respirations, because that will knock them out. So we give Duramorph, which is this morphine that's actually in the spinal, so that's coating those nerves. But this is where the itching kind of happens, that they're just scratching their face, they're scratching their arms and their chest, and this can happen in recovery room. We can counteract that with Benadryl, of course, going to make them sleepy, and Nubain will also counteract all that itching. But we have to count respirations. That's the most important thing. We're going to have her splint her incision when she's moving or coughing, and that's just holding a little pillow. I always like putting a blanket in a pillowcase and taping it closed, and decorating it with flowers and hearts and all of that. That was the Hug Me pillow. But she has to kind of hold her incision, splint her incision as she's moving, as she's coughing. She has to cough to help clear any secretions from her lungs, or she could have pneumonia. And at least I always say that we're chasing pneumonia away with those coughing. And the incentive spirometer, which I'll get to again in a minute. So she holds her incision, and she takes a couple deep breaths and really coughs. She doesn't just clear her throat. It's painful. Having a cesarean is painful. The Duramorph goes a long way in preventing, but it lasts about 18 to 24 hours. After that, she's in pain. So the incentive spirometer is really encouraged, that she sucks up through this tube to increase her oxygen intake and the expansion of the alveoli, and that's more important than blowing out into something. Have her use that as often as possible. The directions are like a couple times an hour, as much as she's willing to do. Teaching the Rita, redness, ecchymosis, edema, drainage, approximation of her incision. I really want moms to look at their incision. Obviously, they have a dressing on for the first day, or about first day. Usually it should be 24 hours. But if you adjust the mirror on the bedside stand to where she's looking, she needs to see that incision. Oh, excuse me. Actually, up to now, she maybe has only seen incisions on slasher movies. And she says, no, I don't want to see it. So, well, let me describe it to you. It's from here to here, and I touch the sides of her abdomen. It's closed. You don't see any redness at all. It's maybe a hair swollen, but you've kept ice on it, which we keep ice on, just like a perineum. We're going to keep ice on her incision immediately after delivery so that it's not too swollen. It really looks wonderful. I'd like you to take a look at it, because you have to tell the doctor when there's any change in this when you go home. So they say, okay, and we tilt the mirror so she can see it. Maybe, lift her head up, put another pillow under it. And she's really curious. Oh, that doesn't look too bad. It's not what I was thinking it would look like. So tell her if it starts to get red around the edges, it shouldn't be swollen anymore, but there might be a lot of ecchymosis. She had retractors put on each side of those incisions, at least the bottom part, to hold the bladder back. It may have some bruising. Bruising will go away. It's not going to get any worse. She may have some drainage, whether it's clear drainage, serosanguinous drainage, shouldn't be frank bleeding. And that if this incision starts to open up even a little bit, then she needs to call the doctor. So telling her all about that, she's more confident in taking care of herself. When she's up to the bathroom, then she can kind of hold her belly up a little bit and look at this incision in the mirror. She still can't bend over and look at this. She is still going to have an abdomen that she can't see this incision. So when you're standing with her in the bathroom, teach her how to just gently hold up what we call the pannus, the bottom part of her abdomen. There's a fat layer there, and she can look at her incision in the mirror. We want her ambulating on day 1. We even want her ambulating maybe on day of. If she had her cesarean 2, 3 in the morning, we want her up at night, going to the bathroom. Catheter is going to be removed. When she gets up, these compression boots are going to be removed, but really not until then, because she's still prone for clotting. Some doctors will want TED hose on for a while. We are really very judicious and very conservative, and doing as much as we want to do. Can do. She's going to be discharged on day 3 or day 4. Vaginally delivered moms are discharged on day 2. Actually, let me get this down here in case this is the one that you're looking at. Nope, it was this one. Discharged on day 2 or 3 or 4. We're going to ask that she refrain from intercourse for 2 to 6 weeks. Sometimes even 2 weeks is way too early. Sometimes 6 weeks is way too early. But this instruction is given on day of discharge. This is not something that's done in the recovery room. So all of these things that we're talking about are kind of what's done. It's what's done as her recovery progresses. When she's going to have intercourse again, we say that she should use some kind of a lubricant, and that her position for comfort is for her to be on top so she can control the penetration and she doesn't have anyone heavy on top of her, hurting her. So if we talk about resuming intercourse, then she's going to feel much more comfortable talking about it, because it's on her mind and it's on the FOB's mind. So we're the ones to bring it up. Other part of recovery is their oral intake. We want her drinking as much as possible. Her breastfeeding is going to be maybe a kind of a day behind, because she has lost some fluid, and her body is thinking of holding on to that fluid for her recovery, not necessarily for her to make milk for the baby. So breastfeeding can take a while to initiate, for the baby to really get any milk. We initiate it early, but it may not work really early. Ambulation, moms after vaginal delivery are up in a couple hours. Not quite so for a cesarean delivery. So it just takes a little time, and we're patient with her. She has to be patient with herself. We're assessing that incision line for skin blisters because her skin was really edematous. We put a very tight pressure dressing because we didn't want anything leaking through, and that pulling of the dressing can cause layers of her skin to separate. So it's not that we caused skin blisters, and if we take the dressing off roughly, it caused the skin blisters, but it may cause that skin blister that developed because of that tension on the skin. It may cause that blister to break. That's painful. The incision's not so painful. It's kind of numb because nerves have been cut, but the skin with all of its nerve endings are really painful. So we can put a Silvadene cream on it to kind of coat it, keep sweat from falling onto it. And actually, as she is up and showering, I always had the moms put the Silvadene cream on that incision, and then all the shower water and the soap and the sweat that's washing off of her isn't going to irritate that skin that would have been covered by a blister, but it's open now. Peri-care is really important, but there's less lochia. Actually, they take a lap pad and wipe out the uterus to get rid of a lot of that decidua and to make sure that there isn't a retained placenta. The mesh panties are given so that there's no pressure on her abdomen. I have to tell you one of the funniest things I'd ever heard from a mom. I was showing her these mesh panties, and she took one look at them, and she said, "You can tell those aren't from Victoria's Secret because Victoria wouldn't keep these things secret." And I tell that to every patient because it just cracks me up every time I think of it. But the mesh panties are really good. Give her an extra pair of mesh panties. We want to help our moms. They probably are very judicious with it in the supply closet, but, blame me that I told you to give her another pair. Itching from the Doromorph, it really, really, really is intense. So give her Benadryl, tell her it's going to make her sleepy. Give the Nubane. One year we had a shortage of Nubane, and it was really awful because we couldn't give it for this itching. Face, chest, upper arms, that does go away after 24, maybe 36 hours is not so bad. We had one doctor who would always say to a cesarean mom, you want to eat up, you want to drink up, and you want to rest up. She cannot be active. She has to stay kind of quiet so all of those tissues heal. You can tell her you were there or you've been to another cesarean. There's a lot that goes on and that needs to be healed. So she cannot be that active. She should not be driving for the first 2 to 4 weeks. She just really has to kind of keep herself rather calm and inactive. So we're talking now about the VBAC with a low transverse incision. Again, that's the uterus, not the skin. Uterine rupture is really very low, 0.5 to 1%. And patients can be counseled about that safe attempt of a delivery. So we call it a trial of labor. We make sure that everything's going okay and that they can attempt a vaginal delivery. It can happen. The body is strong. Those scars that form, sometimes people say they're stronger than regular tissue. Sometimes they say there's a weakness in them, but we can do VBAC. But it's up to the mom. We're not going to force her to do anything. If the incision should be extended or initially made into that contractile part of the uterus, like that's a low vertical incision, but it went a little higher than needed to go. If it's at all into that contractile part, then that risk of rupture is greater, and they may be counseled not to have a VBAC. You want to assess that reason for the primary. If it was because the baby came into some risk and that's why we delivered, that's probably not going to happen. If that cesarean was because the baby was breech, the second baby is vertex, that didn't happen. If it was because the placenta was a previa, and if it's not a previa with the second time, there's no reason to worry that she is going to have a repeat cesarean for that reason. So you kind of have to really see why that first cesarean would have been done. Was it because of condylomata? Was it because of active herpes? Was it mom never went into labor after an induction? That might be repeated. So that's why we do a trial of labor. And if it's not happening, then we'll just repeat that cesarean. We must be able to perform the cesarean in 30 minutes. We can't expect it to go longer. We have to, again, the ideal, and labor and delivery units do drills on this. Call a cesarean, get the baby out in 2 minutes. Sometimes that's what's necessary. We don't necessarily use Pitocin or augmentation. We're not going to use a Cervidil, which we'll talk about later, because we don't want to stimulate the uterus to contract more than it would naturally. And about 10 to 11% of women have a VBAC, but if only 0.5 to 1% there are problems, we could probably be having more moms deliver by VBAC, but that's completely up to them. It's not up to us. And so, be reading that slide. So, risks and complications. This is why we don't deliver everybody by cesarean. The body really does know what it's doing more often than not. So, there is this twofold increase in mortality and morbidity over vaginal deliveries, such that if it was 0.2, it would be 2.2 deaths per 100,000 deliveries. It's not a lot, unless it happens, to you or to your patient or to your sister. So, and that is really related to the delivery and the condition that led to cesarean very often. She was sick already. There was a risk. Fascial dehiscence. So where the skin is going to open up, the fascia is going to open up. It usually opens up just to that muscular layer is a risk. We have to talk about it. Infection is a risk. Postpartum endometritis, which is an infection in the uterus, is a risk. Another wound infection, urinary tract infection. Nicking the bladder. Oh, I talk about that later. But nicking the bladder can be a risk. Thromboembolic disease, deep vein thrombosis, septic pelvic thrombosis. It's like, holy mackerel, having this baby really can lead to a lot of complications. Anesthetic complications, putting in an epidural, putting in a spinal, as rare as they are, we have to say that yes, this is a possibility. Anesthesia talks about that, not us. Surgical injury, a uterine laceration, a little cut somewhere where it shouldn't be, a bladder, a bowel nick, ureteral injuries on the ureters, uterine atony. If this mom was never in labor at all, we do an incision in the skin, we do an incision in the uterus, we take the baby out, we take the placenta out, and all of a sudden we want this uterus to contract. It had no intention of contracting. It was only 36, 37 weeks along. So we give a ton of PIT and we try to get this uterus to contract. And sometimes there's a bit of atony. With atony, there's going to be bleeding. So we're going to anticipate. That's why we always cross-match for 1 to 2 units. Delayed return of bowel function, that can happen. Moms can have gaseous distension and all the walking and the ambulating and the Reglan and sometimes an enema, sometimes a rectal tube, all these different things that we do is a delayed return of bowel function. Those mamas are not happy because the things aren't working. Delivery before the 39th gestation is such a risk, and that's only because we inaccurately dated that baby. So when we say we don't want cesareans before 39 weeks, but we pull out a baby, we deliver a baby that is coated in vernix, and that starts to slough off around 36, 37 weeks, we know we miscalculated. That's not good. That baby could have stayed in there for longer, probably. Respiratory complications in a newborn is what happens when we deliver babies sooner than their respiratory system was ready to start breathing. They could have a longer hospital stay. They could have a placenta previa or an accreta on subsequent pregnancies. These are all risks that moms and families need to know about. So the last slide here is all of the references that I used for this. Your book is a good reference. I scattered the websites throughout all of this. These are just other kinds of, this is another text that I used. So I hope this was informative. Of course, you can ask questions. Yes, there's going to be questions on the next test with this. And hopefully the cesarean rate will decrease over time.